of a invasive ductal carcinoma right here. And here's the ultrasound, how it looks. Look at the hyperechoic rim right there. And look how complex it is, or complicated it is on the inside. Hyperechoic. Alright? Same thing here, have the angular margin right there. And you see they're not like perfect circles or just defined. Bless you. Margins right here. Okay. And these are just some images out of the book. This would be considered a high-grade breast cancer right here. Again, you see the kind of cystic formation within those. And this is invasive ductal carcinoma with duct extension, with extension into the duct, meaning that this tumor is growing in the duct. Okay. And just some other images of some invasive ductal carcinoma. Okay. So, invasive lobular carcinoma. I know it looks like a lot of words. I was trying to make it on one slide for you guys. Okay, so invasive lobular carcinoma is the second most common invasive breast cancer. Okay. The first most common is
He says your first IDC.
IDC. Invasive ductal carcinoma. But it's the second most common, and with diffuse growth pattern. Higher rates of being multifocal, multicentric, and bilateral than invasive ductal carcinoma. Guys, write that down. That's important. Higher rate of being multifocal, multicentric, and bilateral than invasive ductal carcinoma.
So it's like LCAS.
These tumor cells line up and infiltrate the stroma in a diffuse manner and less often form a solitary, discrete mass. Okay? It's a hard, fixed, palpable retraction of shrinking breast. It's kind of have that similar appearance to the IDC as far as the skin retraction and the straightening of the Cooper ligaments. Okay? Mammo may underestimate and miss an invasive lobular carcinoma. Sonographically, the appearance varies, ill-defined, irregular, hypoechoic, solid mass without acoustic shadow. Okay. And this is how it appears. Here goes our invasive lobular carcinoma. You don't really see the borders that well. See that borders aren't hyperechoic, well defined. You know, just kind of laying in there. There's no clear delineation of this mass. Okay. And the mass, of course, again, this one also has indistinct borders. Okay? They're not hyperechoic like the ductal carcinoma, invasive ductal carcinoma. All right, so those are our two invasive types. The first and second most common. Okay? Invasive ductal carcinoma, the most common, and invasive lobular carcinoma. All right, so let's get into these special type invasive ductal carcinomas. These special types of carcinoma. So they're broken down in they have 4 of those special types. There's going to be medullary, colloid, papillary, and tubular. Okay. These are a small subgroup of invasive ductal carcinomas. Okay. They have a better prognosis than invasive ductal carcinomas, NOS. Okay. So our first one will be medullary. It occurs in 5 to 7% of breast malignancies. It's a well-marginated cellular tumor containing prominent lymphocytes and plasma cells. It's discrete, round, soft, and mobile. Rapid growing, most in the upper outer quadrant, as with most breast cancers. Okay. On mammogram, it's radiodense. And sonographically, it's oval, solid, hypoechoic with distal enhancement, echogenic halo, and prominent vascularity. It presents similar to a IDC.
What's that echogenic halo?
Meaning that it has that borders defined around it, and it's really bright all the way around. Remember, like I showed you the picture of the IDC and how you can see perfectly the whole halo around there? I'm trying to think of something else that has an echogenic halo to it.
I saw one yesterday, the IBC. It's really
I can't think of anything right now.
halo.
So that's our medullary type of special type IDC. Our second type would be our colloid or mucinous carcinoma, and it occurs in about 2% of breast malignancies. It is uncommon, a circumscribed gelatinous lesion, slow growing with high and low density. Sonographically appears oval, circumscribed, meaning it has well-defined borders, with possible lobulation and microlobulation, isoechoic to hypoechoic, homogeneous or mildly heterogeneous. That sounds like it looks like a lot of stuff. It's hard to determine whether it's a colloid carcinoma or not.
It's like B-net because it's microlobulation.
It's tough to say. That's why I said I'm not gonna have any pictures, because unless you just memorize the pictures, it's gonna be hard to be like, oh yeah, that's how this appears on the sonogram. Oh yeah, that's this and that's that. Again, we don't know until the actual biopsy itself. And this colloid carcinoma, kind of gelatinous, almost look like a complicated cyst. Yeah, this one doesn't even have the echogenic halo. Meaning, like right here, Myra, I would say echogenic halo would be similar to like how the aorta wall looks around the aorta. That bright wall around the actual mass itself. Okay. My third special type IDC would be capillary carcinoma. It appears in 1 to 2% of breast malignancies. It occurs centrally within the breast from malignant transformation of large duct papilloma, or develop within a peripheral TDLU. It is focal or multifocal and slow growth, and tends to be larger with expansion into the duct and branches into the adjacent ducts. And that's what they mean by like invasive, meaning it's invading other spaces that it shouldn't be. Capillary carcinoma is also solid or intracystic. Those are the two types right there. Okay, it has a higher incidence in men. Radial and anti-radial scans are the best, and color Doppler demonstrates prominent blood flow. Okay, again, this papillary cancer affects, the duct, so of course radial scans and anti-radial scans are going to be good with seeing them. Intracystic lesions are complex with solid and cystic components or a mural node. This right here is an image of an intracystic papillary carcinoma. I think it's 172 slides or something like that associated with this PowerPoint. It's huge.
How many slides?
Like 172. Huh? It's not bad?
Okay.
You got some reading to do this weekend. Okay. So our last and final special type, invasive ductal carcinoma, would be a tubular carcinoma, and that occurs in 2% of breast malignancies. Okay. It's a real differentiated invasive cancer. It's very small, less than 2 centimeters, slow growing, incites prominent reactive fibrosis, often develop in the TDLU and can arise from a radial scar. Palpable fixed lesion associated with skin dimpling. And on mammogram, it appears it's small, irregular, radial dense mass with long spicules. Spicules are, I don't know if you remember seeing that image earlier, it looked like have those points coming out of it. You know what I'm talking about for the image earlier? No? I'll show you in 1 second.
Oh, the regular walk.
When they're talking about spiculation or spicules, it kind of has like a. Pack mine here with the lights. Kind of has like.
Pantry.
Those are spicules. They kind of spread out. Spikes. Yeah, spikes. I like that.
Spikes.
I like that. Okay. I can't see anything. All right. And this I had appeared, you see, it's not a well-defined cancer. These are the type of things like that are hard to spot. Like when you're doing breast cancer, that's why I give those ladies the most credit, because they have like hawk eyes to be able to find these type of lesions that lie within breast tissue, because they're so ill-defined and so hard to see. Like if I was doing breast, it would be difficult for me to see those, because I'm not used to that. Okay? And that's why you have to move very slow, because that memory layer can look the same throughout, even though you might slide over something like this and miss something. So it's tough. It's tough to do breast, but you know, they do a good job of it. Okay. So done with those, on to our next cancer, would be inflammatory carcinoma, right here. And this is a highly invasive cancer that infiltrates the lymphatics of the skin. Again, what are the ways that cancer is going to metastasize? What are the two ways? The lymph, the bloodstream. Okay. Lymph nodes and the bloodstream. Those are the two ways that cancer is going to metastasize. Okay. Inflammatory carcinoma is going to metastasize by the lymphatics of the skin. Okay. The skin is rapidly red, warm, and edematous. Develop orange peel appearance, meaning they have those little dimples in it. You know what I'm talking about, how orange peel looks with little dimples in it?
On the breast itself?
Yes, on the breast itself. Okay. It's painful and hard, and the lymph nodes are palpable. Right? Sonographically, thick echogenic skin, dilated lymph vessels and veins, and hypervascular. You have a poor prognosis for this particular cancer. You can even see on this mammogram right here, look how thick this skin is right here. Look how thick this skin is. On the sonogram, you really can't tell, because to see the skin line, you probably need a standoff pad, right? To be able to see that skin line very clearly. But a telltale sign would be, of inflammatory carcinoma would be the skin thickening, orange peel appearance. Okay? And that's how it looks on ultrasound right here. And again, guys, know these views. Know these views of mammograms too. Well, the two that we focus on. Okay. Metastatic carcinoma has a variable appearance, and the mets travels via lymph channels, blood, or just direct expansion from a nearby or neighboring organs. All right. So the spread of cancer from the breast is one way to metastasize. You know, meaning that you have breast cancer and now it's spreading out to somewhere else. Okay. The first site is often the ipsilateral axillary lymph nodes, same side lymph nodes. That's going to be the first site of metastasis for breast cancer. Okay. Of course, those are the most nearby. Receives most of the lymph drainage, right? We talked about that. The axillary lymph nodes receive most of the breast lymph drainage. Okay. Sentinel node, the first node of drainage basin. Sonographically, a suspicious lymph node is enlarged. Remember, it's rounded. Hypoechoic. Remember, it's going to lose that loss of the echogenic hilum. Okay, and indistinct margin. Okay, again, it's not going to look like a football anymore. It's going to look more rounded and hypoechoic within it. Okay. The most frequent sites are going to be bone, liver, lung, and brain when we talk about metastatic carcinoma from the breast themselves, from the breast. Okay. Again, those most frequent sites are bone, liver, lung, and brain. Okay. And it makes sense that the ipsilateral meaning same side, right? The ipsilateral axillary lymph nodes are going to receive the metastasis first, right? So let's talk about spread of the cancer to the breast, meaning that another cancer is going to invade the breast, and the breasts are going to have metastasis. Okay? Meaning that if I had liver cancer, then it spread to the breast. All right. So that's very uncommon, guys, for a cancer to come from somewhere else and spread to the breast. However, if it does reach the breast, it's going to reach the breast via blood or the lymphatic routes. And the most common source is from primary cancer of the contralateral breast. Okay, that's going to be the most likely spread of breast cancer is going to be from you got breast